Dear colleagues, it's a pleasure for me to explain you the revolution on insights in psoriasis and the therapeutic possibilities for patients with psoriasis. A lot has happened during the last 10 years. These are my conflicts of interests. Firstly, I would like to comment the following, that when I started as a resident in dermatology 40 years ago, psoriasis was regarded as a skin disease. And now, during the years, we have learned it's not just psoriasis of the skin. Psoriasis is a systemic disease of inflammation with comorbidities, including psoriatic arthritis, metabolic syndrome, cardiovascular diseases, mental health, and inflammatory bowel diseases. 40 years ago, we had some topical therapies, and maybe an occasional patient was treated with a systemic therapy. TAR treatment and desranol treatment were quite frequent in those days, but now topical therapies have developed with vitamin D, often in combination with corticosteroids, occasionally desranol treatment. Phototherapy and actually laser therapy, laser delivery of UVB also is used in the treatment of psoriasis. We had a classical systemic treatment such as acetylcholine methotrexate, cyclosporin, and dimethyl fumarate. But now there are innovations with apremilast and an important innovation during the last 20 years, biologics, medications produced by living organisms and targeted highly specifically at some pathways. The anti-TNFs, anti-IL-12/23, anti-IL-17, and anti-IL-23. In the pathogenesis of psoriasis, we got new insights. That is, in normal epidermis, the skin is challenged by aselective challenges, but also by autoantigens. And the results of this is that plasmacytoid dendritic cells are activated to produce interferon alpha. And interferon alpha in early psoriatic lesions stimulate and activate myeloid dendritic cells, which cells travel to the lymph nodes. And it's quite interesting that right from the beginning, psoriasis also should be regarded as a systemic disease involving circulation of myelodendritic cells to lymph nodes. And from the lymph nodes, activated T cells, predominantly T1 and T70 cells, travel and are accumulating in the skin. And what are they doing there? They are producing cytokines. And a very important, crucial cytokine proved to be IL-17, in particularly IL-17A, IL-17F. And in collaboration with other cytokines produced by these cells, the epidermis is activated. And again, we see signaling by IL-36, and again, stimulating the plasmacytoid dendritic cells. So there is a circular activation. At the same time, we see that IL-17 releases in the epidermis chemokines, which chemokines activate and attract other cells to the epidermis of the beginning psoriatic lesion. There's neutrophils, CD8 cells, dendritic cells. These cells accumulate in the skin and again contribute with the production of IL-17. So important new therapeutical principles, anti-TNFs, TNF-alpha being a ubiquitous cytokine, anti-IL-17, targeting more selectively IL-17 as a crucial step in the pathogenesis of psoriasis, and anti-IL-23, which targets actually IL-23, relevant in an early stage of the pathogenesis of psoriasis, but also in a late stage in the pathogenesis of psoriasis, where tissue TRMs are responsible for the continuation of the psoriatic lesion. During the last years, new treatments have appeared. Anti-TNFs, 4 different compounds. Anti-IL-17s, we see here 3 compounds on this slide here. And anti-IL-12/23, anti-IL-23s, 3 different compounds. These compounds permit a sustainable disease control. And here we see the earlier biologics, which are the anti-TNFs predominantly, but with the anti-IL-17s and anti-IL-23s, we see that an ambitious therapeutic target now is possible to reach in at least 50% of the patients. That's the PASI 100. I couldn't have dreamed 40 years ago that this would once be achievable. And that means that our aim can be indeed in clear skin to reach that or nearly clear skin in the majority of patients. Important innovations are emerging now. There is insight that the gene for the Janus kinase TYK2 is an important gene in the signaling of several cytokines, interferon alpha, IL-12, IL-23. And when we inhibit TYK2, we inhibit actually the signaling of these cytokines, which are highly relevant in the pathogenesis of psoriasis. And we have seen that deucravacitinib now in the clinic is able to improve psoriasis at the level of PASI 75 in the majority of patients. There is apremilast, which is a phosphodiesterase E4 inhibitor. This inhibitor in the signaling of the epidermis, in what actually happens, it increases the accumulation of cyclic AMP, which results in a different expression of certain transcription factors, resulting actually in a reduction of the psoriasis-relevant cytokines and some increase in cytokines which are acting against psoriasis. And what we see is that a modest improvement is possible with this relatively new small molecule that's a PASI 75, 33% of the patients. Apremilast is also a phosphodiesterase E4 inhibitor, which has been developed for the topical treatment of psoriasis. And also in the topical treatment, we see an innovation with tapinarof, which is a compound which binds to the aryl hydrocarbon receptor, resulting in a modification of transcription of psoriasis and atopic dermatitis relevant cytokines, and interfere with the antioxidant response and also with the skin barrier. And tapinarof has an improvement at the level of PASI 75 in 40% of the patients and will innovate the topical treatment of psoriasis. Dear colleagues, psoriasis is more than skin deep. We look at the skin as dermatologists, but we also know that the anti-TNFs, anti-IL-17s, anti-IL-23s, the TYK2 inhibitors and apremilast are effective beyond the skin, have an improvement of psoriatic arthritis. And in the future, as dermatologists, we will need also to capture the improvement, not exclusively at the level of the skin, but also with respect to the comorbidities. An important development in generalized pustular psoriasis has taken place. That's the insight that IL-36 signaling is highly relevant to the pathogenesis of generalized pustular psoriasis. And what investigators have shown is that can be at least three different pathogenesis at the level of the gene. That is an IL-36 receptor antagonist loss of function mutation, a CARD14 gain of function mutation, or a loss of function mutation AP1S3. And the result of these genetic alterations is an increased level of IL-36 signaling. And a new compound has been developed as an antagonist against IL-36, which resulted in only one injection here in the phase 1 studies in a considerable improvement of generalized pustular psoriasis. Only one injection resulting in a dramatic improvement in 6 out of 7 patients. Actually, clear skin was reached. And this was confirmed now more recently in a larger clinical trial. So in conclusion, insights in pathogenesis of psoriasis have been crystallized now in a branching model of innate and acquired immunity. A constellation of susceptibility loci has been established entirely congruent with this immunopathological model. And inspired by these insights, pathogenesis-based treatment have now emerged with an unprecedented efficacy and sustainability, reconfirming that these insights in pathogenesis are relevant to the disease. And psoriasis research and treatment development is really a showcase par excellence of translational medicine. Thank you so much.